So we will come to the agenda. The agenda is that there is no presentation as such. It's not that somebody is going to teach other people what to do, what not to do with regards to the internship. The idea is to share the experiences related to the points that I shared in the WhatsApp group regarding this internship, the newer aspects of the internship. So, internship in community medicine has undergone a change as per the guidelines mentioned. And now, earlier we used to have rural and urban health centers, and the interns were posted there. Now they mention that the interns in community medicine must be posted in medicine, gynae, and pediatrics for 9 weeks, and then for 3 weeks in community medicine. So this is a big change, and the obvious point that comes to our mind is, do we have medicine, surgery, and gynae departments under our domain, and how to do that? So that must be the obvious challenge that you all must have faced, and we all must have also tried to resolve it to the best of our own capabilities and interpretations of the document. So I will. There are a few points that we want to discuss. I will mention the first point, and then we will invite inputs. I will share our understanding, and I will also invite your comments on that. So the first question that is there is, how many centers will you require now as per the batch size? Because the batch size of 15 that has been set up, that at any one place not more than 15 interns can be posted. So at places where 150 students are there, and even where 100 students are there, and at places where 200 students are there, so many interns, how are they being managed? How many centers are being required? So this is the first point that I think we need to discuss. So any comments on this, that how many centers are you all having? I will share our experience. At our place, we had one rural residential center hospital, a secondary level hospital, and one outreach rural center, and we had one urban health center. Now the challenge is that if we want to post in medicine, gynae, surgery, so that the rural hospital, secondary level hospital that is there, now we have to post our interns in that hospital. So at any given point of time, the number of interns at that in that hospital exceeds 15. So how to manage this? One interpretation of the thing is that 15 students at one place of posting. Should we take this 15 students as one department? That in medicine department, 15, not more than 15 interns, or should the unit of the place of posting be considered the whole hospital? If we consider the whole hospital, then we need to have, then with the 15 interns being posted at in one hospital, that means we can post 5 in medicine, 5 in gynae, and 5 in surgery. So that is a challenge that we are facing. So we are trying to get some other hospital, secondary level hospital, where we can post our interns. The search is on, and with the state government, interacting the state government, we hope we will get that. So that is one thing that we faced. So we want your inputs. How did you? How are you trying to manage this issue at your place, if there is? You can unmute yourself and you can comment. You can tell your name and college name if you want to, and if you don't want to, you can avoid that. If you want to, you can say, and then you can share about the number of students and number of centers or hospitals that are required for you. You can also write in the message box if you want. Dr. Manoj Arvind has written, I'm associate professor in Telangana. Internship expected to begin from 2019 batch. This internship is as has the clarification also come up that the internship that is to begin from this year, the 2022 itself. Those students who are to begin internship from April 2022, for them this new guidelines are applicable.
Good morning. This is Dr. Kokila Salvas, sir.
Yes, hello Kokila ma'am, how are you?
I'm fine, sir. Fine, sir.
Yeah,
We
nice
are having only yes, sir. We are having one rural center and urban center alone, sir. We don't have any secondary care hospital, sir. How to manage this situation, sir?
Yes. So this is the issue that is coming up. So that is why we are trying to discuss this issue, that we will have to find out solutions also. To some extent, we'll be able to do it. Some extent, we'll not be able to do it. Um, did you as you have RHTC and Urban Health Center, Rural Health Center under your control?
Yes, sir.
So I don't think you will be having medicine, gynae, or surgery department in those centers, is it?
Yes, sir. Yes, sir. Yes, sir.
Okay. So any plans of having some agreement with some hospital in your
We are planning,
district?
sir. Actually, we asked one faculty from each department to come and on daily basis to our center so that we can give them separate place and then we can post them under them. Sir, is it okay?
This is
Or we can put a
one
MOU.
of the idea.
Otherwise, we
Okay.
have to put MOU with the government health center, secondary hospital, and then we can post them.
Okay. So these are the two like approaches that you all are thinking.
Yes, sir. Yes.
Okay.
We want
Okay.
the suggestion from the group, sir.
Yes. So let us hear from others also. Thank you for
Yes.
sharing your point. This is a kind of a formal or informal discussion amongst our colleagues. We thought that rather than having formal sessions and all those things, when we want to find out how to solve certain issues, we should come together and try to discuss amongst ourselves so that we might get enriched by the diverse perspectives. Dr. Vishweshwara Rao is mentioned in our state area, hospital and community health centers are separate, both at secondary level. Is it mandatory to post in CHC only? Dr. Vishweshwara Rao, can you unmute yourself and communicate? It will be better for us to understand your
Sir,
perspective.
good afternoon, sir.
Yeah, good afternoon.
I'm from Andhra Pradesh, sir. So in our state, there are two separate secondary level hospitals are there. Sir. One is area hospitals, another one is community health centers. So both are separate name, but both are secondary level. So in that NMC document, it is marked as it is to be posted in community health centers only. So people are thinking that we should post in only community health center, not in area hospitals. So there are some doubts, doubt regarding whether to post in secondary level or definitely in community health center. There is the doubts.
Okay. So regarding where to post, I think this is the one point that is coming up. What I think is that what they have mentioned is like one is uh, taluka. The place of posting is not very much specific. Other than that, what comes out is medicine, surgery, and gynae department, and these three departments are available. I think in CHCs also. These three departments are available in taluka or district hospitals also. So, if any of these hospitals are there with which you can form an agreement or an MOU, and you can post your interns to those departments in those hospitals. If there is a CHC where medicine or maybe gynae is department is not available, not functioning as such, then I think those CHC will not be suitable for this purpose. But if there is a CHC where medicine, gynae, and surgery departments are functional, then you can post your interns to those CHCs, or taluka hospital or district hospital, whichever secondary level hospital is there, but not medical college hospital or a
Yes.
tertiary care institute. That is not allowed.
Yes. Yes, sir. Thank you, sir.
So that is my understanding. We all are struggling with this.
Yes, sir. Yes, sir.
But what Dr. Kokila mentioned about this, that if we can post some faculty from the medicine department to our health centers, and we can say that is an exposure of medicine or surgery or gynae, that we need more opinions on that also. That is another point of view that is there. We should acknowledge all the points of views.
Yes, sir.
Any other comments on size of the batch and how many is anybody struggling with the number of centers or number of hospitals regarding this 15 size that batch size that has been specified?
I'm Dr. Sujit, sir.
Yes,
Can I-
Dr. Sujit.
I'm associate professor in community medicine. So actually, for community medicine posting, we don't need all the people at a time. They will be divided into many batches. So for community medicine, we get around 40 to 45 students at a time. So 3 CHCs, maybe 15 in each CHC, will help in dividing those 45 students into 3 centers. So that way, we are doing it. And one more thing that Kokila madam, what she said is bringing faculty from other departments to the health centers. Now the question is about the infrastructure for pediatric people, OBG and medicine people to really do a secondary level service at the health center is a really question that I have.
Yes, Dr. Sujit. So you are at your place, you are posting in 3 PHCs?
Community health centers, 3 community.
3 community health centers. Okay. So you have 40 interns, around 40 students at any given point of time. So you are posting in the 3, dividing in the 3 CHCs.
Yes, yes, sir.
Okay, and must be rotating with your what about the 3 weeks of community medicine? That is in a separate.
We are doing 1 week in rural health center, 1 week in urban health center.
Acha.
And then,
1 week either in rural or in urban.
but yes,
Okay, and 3 weeks in the 3 CHCs. Okay,
Yes.
that is good that you have these CHCs around you and you have an agreement with them. That is encouraging to note.
so about this question, like I was asking, if you are deputing faculty to the health center we are already having, so do we have the infrastructure to treat at secondary level for pediatric? OBG?
Yes. So the point I think in message also some point have been mentioned. The posting from other department is not possible. We are not getting permission. So yes. So yes, this is an issue because if we look at the competencies and we look what the internship guidelines mention, they want to expose the interns to the secondary level hospitals. So if we post them at the centers, even though medicine faculty or some healthcare provider from medicine or surgery or gynae, they come to the center, our center. But yes, that skill that is needed regarding managing pediatric patients at the secondary level, whether that can be achieved at our health center is difficult. It's questionable. So I think that that doesn't seem right now at most of the places. I don't think that our health centers can be by adding manpower, specialist manpower. I don't think we can convert it into something like a secondary level care. At some places, if it is there, but that has to be dealt with a case to case basis.
It's true only, sir. I accept.
Yes,
That's
ma'am.
idea in our mind.
Yes. Then thank you very much for sharing. So at some places it might be feasible also. At some places the health centers are quite well developed, and there are certain things needed to be added, and they can convert it into a kind of secondary level facility. Some point, Dr. Shri Vidya Bodhi, in private medical colleges, we are not getting permissions to send to community health centers and area hospitals. Yes, this is a challenge. But this private and government thing, do you think it is that much coming into picture as an obstacle? Like because a particular institution is a private institution, so if they approach the district hospitals or secondary hospitals or taluka CSC hospitals, then the probability of getting permission is less as compared to if we the request goes from government side. And is it also possible that the private hospitals, in terms private hospitals won't get permission to post their interns in the CHCs or these district hospitals? Is it an issue, like one faculty has raised this issue, so we want to know from others also what is the situation?
Yes, sir. It's difficult only, sir. That's why we were having the idea of putting the faculty, sir.
Okay.
It's difficult
Okay.
to get permission.
That is the challenge that we are facing.
Yes. Yes.
Sir, I am Dr. Smita.
Yes, Dr. Smita. Yes, ma'am. Please.
Sir, namaste.
Namaste.
Sir, actually, this 12-week duration in community medicine, they have divided into 3 weeks in each, and community medicine 3 weeks. We used to post the interns in immunization and ARV OPD also, and in urban health training center previously, sir. It is going on. I mean, what was our practice? I'm just sharing with you. And
Yes.
in PHC, there are a community health center associated with the rural health training center. And under that community health center, there are PHCs also. And we post the interns there. We used to do that. But how we will manage now, sir, this 3 weeks duration and all? District headquarters also, we have access to district headquarters. We can talk to them and regarding this this medicine and surgery and OG specialists, and the cases can be shared. So how to manage the community medicine 3 weeks, sir? Community medicine 3 weeks.
Yes. So earlier we had 8 weeks in total, 4 weeks rural and 4 weeks urban. Now all that has compressed to 3 weeks in community medicine. So we can post our interns in community medicine health centers for only 3 weeks, and the rest 9 weeks we have to hand over our interns to the hospitals to post them in medicine,
Yes.
gynae, and surgery departments.
So
So,
this sir, yes.
So
This
that
community
is the
medicine
mandate,
part,
right? So do you think, ma'am, that are you hinting that this is diluting the community medicine exposure part for interns? Like
no,
it is
no, sir, that
the
is,
time is very less.
that is, I'm not thinking that they are diluting it, because they have written also. I have seen that NMC document. They have written in detail that what type of exposures regarding the programs in primary health centers and in district head DHH, and regarding different programs in community health center, community medicine, they should get exposed and all these things. Theoretically, it sounds good, sir. But when we are
Yes.
coming to do, we are
Yes.
thinking it to do. We used to do, sir, in CSC, RSTC, that is Rural Health Training Center, and PSC postings. But in community medicine, we used to give them training in Urban Health Training Center, which is also nearby to our medical college. And that this family and all these community level engagements and exposures are also there. And in ARB clinic, immunization clinic, we had a exposure of pretty period, that is 10 to 14 days. We used to do, because immunization and all these things exposure here also, it has been given regarding cold chain and all these things. Immunization clinic, they should get the information and training, teaching, everything. So
but now
DHS,
yes, I think now we can't post for like a longer period of time, like 1 week or 2 weeks in ARV or immunization clinic as such. That seems to be difficult. And another thing is, when we send the students to the district hospitals or to the CHCs in medicine, gynae, and surgery, what competencies will they be able to learn from there? What they have mentioned, if you look at it, there are many competencies they have mentioned, but whether they will be involved in managerial and administrative activities
no,
at
sir,
the
no, sir.
CHC or district hospital,
They
whether
will
they
not
will
involve in
whether
managerial.
they will teach about the health programs at those centers, whether they will be exposed to family, and also I think at those centers in the district hospitals and CHEs and all, they will be only understanding the taking care of patients at the secondary level.
Yes,
That is the common problems, health problems at the secondary level. So I also think that the number of competencies that they will be able to achieve at these three centers, at these three departments in the CHC or district hospital will be very less. In the 3 weeks that are given to community medicine, we will have to teach a lot of things to them, whether it
yes,
is family health advisory related things, or whether it is immunization, whether it is management, data records, epidemic investigation,
yes,
all these things we will, and health education. Do you think that that is the issue?
yes, sir. That is the issue actually. And DHH posting, district headquarter hospital posting is it mandatory, sir, or secondary hospital at secondary level we have to manage?
Okay. My interpretation in our department, when we discussed, Dr. Somdatta is also here. Dr. Somdatta and myself is from community medicine UCMS. We both actually thought about having this discussion, and we were thinking about this internship program.
Sir.
So our interpretation was that it is not possible to suddenly, because earlier it was only RSTC and UHTC with us. Suddenly having everything, like we get an MOU from district hospital also, we get MOU from CHC also, and all the levels or more than one level, it is very difficult. So we thought that we zeroed in on this point, that let us have one posting in either RSTC or UHTC, that is community medicine 3 weeks, and one 9 weeks posting in some hospital, any secondary level hospital, either taluka or CHC or
Yes.
sub-district or district hospital, but below the medical college. So this was our idea, because that is what seems to be feasible at first go. Even that is a difficult thing. At many places, as has been shared by other faculty members, it is not so easy to get MOU with the other hospitals. Suddenly, all of a sudden, we go and say from tomorrow, our interns will be posted at your place. That system is also not geared for this particular kind of training. So suddenly they also require time to adjust, to acclimatize, to understand. So I think right now we should not think it as mandatory that we should send it to district hospital also and send them to CHC also. So venturing into but anyone is fine if you get an MOU with anyone. I think if there are medicine, gynae and surgery departments in any one of these, either district or CHC, then you can start posting them at that point. That
Sir,
is
what
what
about PHC, primary health center?
primary health center doesn't have gynae medicine and surgery
No,
department. So
no,
that
sir. But the competencies they have mentioned, PHC oblique urban health training center. They have written urban
yes,
health center.
yes.
Yes.
So we thought that PHC will be like a community medicine training. That they have mentioned 3 weeks of community medicine. That can be either in PHC or in rural health center or urban health center, because those competencies we can take up there.
Yes, sir.
And we also found that many competencies they have mentioned in the district or hospital or CHC taluka hospital under those headings.
Yes.
But we think at those places it will not be possible, like health education and all, and management and documentation and all those things. Hospitals people will not expose or will not be able to give that kind of access to those records and managerial activities to an intern in those hospitals. That I think will be a challenge.
Yes, sir, that is true.
Thank you, ma'am.
Thank you, sir.
Any other comment?
Hello,
Dr.
sir. This is
Shraddha?
Dr.
Yes.
Shraddha. Yes, sir. So regarding mentor, they have mentioned that there should be a compulsory mentor involved in the posting. So who that it can be, because the postings they're posted in CHC, PHC, urban health centers. First we were having only MO in charge who used to give sign, and then the taken from the HOD.
Yes.
Hello.
In terms for mentors, they have mentioned a definition of mentors. So that is pretty
Sir.
clear that mentor is any a person in community medicine who has got a degree of community MD, who's a postgraduate in community medicine. So intern
but
is
sir,
what we think is junior resident cannot be an intern, and
Yes,
senior resident can be an intern by this definition. Faculty can be an intern. Any assistant professor onwards, any faculty can be intern. Senior resident can be a mentor. But I think medical officers cannot be a mentor. Lady medical officers who don't have a postgraduate degree in community medicine, if they have a degree, suppose a DGO or gynae of some degrees there, so they don't have postgraduate degree in community medicine. So as per the definition, they can't be the mentors. So mentor can be either any faculty or senior resident, because by definition. So that is our understanding, Dr. Shraddha. Open to
okay, sir.
more opinions.
So regarding the skills and those procedural skills which are given, so how can a mentor look into it? Because being posted in other centers, that's going to be a tough job, sir. Because
Yes, we also echo your thoughts completely that if if we post the interns to some hospital, district hospital or CHC, and at that place it will not be easy for our one mentor to be there and monitor them, and because they will be under the control of the hospital administration there, and
yes, sir.
having two like two administration or two types of people who are monitoring them, two categories of um, uh, authorities over the interns, that will be difficult. That's a challenge. So what can be done? I think it cannot be done on a regular basis. We cannot post one senior resident continuously in the hospital just to supervise. Then the hospital
Yes,
authorities
sir.
may feel they are not trusting us. They have put one person from their department to see whether the things are going fine or not. So there
Yes,
can be these issues, and if one senior resident is there and just observing, so the hospital might feel to give that SR also some job or some task in the hospital, that you also get involved. And then if that happens, then they will not be able to monitor. So
yes,
this
sir.
this is a challenge. So maybe we can have some. I'm just thinking aloud. These are not any guidelines. We are just struggling to find out some ways to manage it. So one way can be like some senior resident is made a mentor for those who are posted in a CHC, and they visit those places on a regular basis, maybe once a week, or we call the interns from there and have a meeting in the department once a week or once in 3 weeks at the end of the posting. So something like that. If so, because we will have to develop a mechanism of intermittent supportive supervisory visits, so that the senior residents or some faculty can visit those places, interact with the interns, with the administration in the hospital, and after having that dialogue, can understand what is going on, whether the internship training program is going fine or not, and if there are some changes to be made, that senior resident or faculty can come back and discuss in the department with the head of the department, and they can figure out how to modify, how to bring it on track, because over a period of time it might happen that the hospital may start taking in some places, I'm not generalizing, but may start taking some giving some task to the interns that may not be there in their guidelines. So that way their
Yes, sir.
training program might get diluted. So we need some checks and balances sort of thing. Those mentors can help us in seeing to it that what the assigned tasks are and competencies are that are being covered during the posting largely or not. So that is my idea, but more points. I think Dr.
Yes.
Sanjay Khandekar has raised his hand. Dr. Shraddha, you wanted to ask something else also?
Thank you, sir. Sir, thank you, sir.
Okay, thank you. Yes, Dr. Sanjay, please, you can unmute yourself.
Sir, good afternoon, sir.
Yeah, good afternoon, sir.
I have two questions, sir. One is regarding posting of interns. We are finding a bit difficulty. We are having around 18 interns in one center, sir, at present, if we are dividing them. That is one part which we are facing a difficulty in posting them right now. And second question is, can a specialist visit for once a week be considered as a posting under that broad specialty?
Yes, Dr. Sanjay, we discussed in this when we started the meeting in the initial few minutes, we discussed and deliberated over this aspect, and what consensus came out was that if the center, because the idea or the intention to post the students in medicine, surgery, gynae at secondary level is that they are able to see how the patients are managed at that level, what type of patients are there. So that was the idea, what type of emergencies come to the secondary level hospitals. So if we have our urban health center and rural health center and we start posting faculty from our medical college like medicine faculty or surgery or gynae and or senior residents, some specialists there. So, but the intention that is there of the posting will be missed. They will not be, because our urban health centers and rural health centers largely they are not well equipped like to manage pediatric patients as such, admissions and management and then discharge. So even for surgery and gynae. So in the lack of the appropriate hospital ecosystem at our urban and rural health centers, if the just by adding manpower, we can't say that that exposure has been given, because the exposure is not only a manpower or a specialist. The exposure is the whole ecosystem where a student understands the patient's emergencies coming to the centers, whether the management related infrastructure, patient management related infrastructure is there or not. These points will have to be considered. If in some health centers this is available, that they have patient admission related facilities and management related facilities related to pediatrics, gynae and surgery, maybe in those centers it may be a possibility. But in most of the centers we don't find that there are admission related facilities available specific to gynae medicine and surgery related patients. So that's why, Dr. Sanjay, it seems difficult that we can consider that. That is our understanding that we are all deliberating upon.
So what should be done in this scenario, sir, where we don't have a facility for admitting or managing a patient of obs gynec? Then how we should post the interns there?
So what has been coming up in the discussion is that everyone seems to be like looking out, searching for some CHC, district hospital, taluka hospital, some secondary level hospital in their nearby areas, where with whom they can form an MOU and they can start posting. And those places must have medicine, surgery, gynae departments, like some CHCs, even district hospitals, taluka hospitals. If they have these medicine, surgery, gynae hospitals, then medical colleges will have to form an MOU there and formulate an MOU and then post the interns there. Because medical colleges within their own ambit, they don't have secondary level hospitalization facilities. Either they have a medical, the teaching hospital that is there, but that is always called as a tertiary level. So we can't post in our own teaching hospital, medicine, surgery, and gynae department. So the only way is that it is like now become kind of mandatory that we have to form MOU with CHC or with some district hospital or taluka hospital so that we can start posting our interns there.
Thank you, sir.
Even though it is very difficult, it is difficult because as some have mentioned in the message also and also mentioned in the earlier discussion that getting permission from the hospitals is not an easy job at all the places. At some places they might welcome, at some places they might not. So in that case, what will the medical college do? And there are many medical colleges coming up in every district. So in some districts where there are like 4, 5, 6, 10 medical colleges now, if there are not that many CHCs in the vicinity or district hospital in the vicinity functional to that extent, so at that in those places also it might be a problem. That I think so.
Thank you, sir.
Thank you. We also need to plan for the college challenges of the liaising with newer hospitals. As we earlier had posted, yes, we have to form liaison with other hospitals. Family adoption program, Dr. Shri Vidya Bodhi, family adoption program is there where faculty has to be mentored for, and again, how the faculty can manage, and again, mentor for these postings. Family adoption program is a separate program. Today, we are not discussing about family adoption program as such. We might consider to discuss about family adoption program. We may discuss some time later in maybe next week or after 1 or 2 weeks. We will try to have some regular discussions amongst ourselves and try to find out what can be done. And even if we need to give feedback to NMC or something from our deliberations, if some points come up, we can also free to send recommendations to NMC about what we are facing. Yes, Dr. Shri Vidya, ma'am, I understand that yes, it's going to be hectic. All CBME is very hectic with small group teachings, STLs, ADCOMs, family adoption program, pandemic module, and now internship में जो change है. So it is we all are in for a tough ride here. Dr. Anil has mentioned I joined late. What was discussed to be learned by internships? Okay, so we will come back to that, Dr. Anil, in some time. Before moving ahead, I think there were some points that we have not touched upon. How are you managing the residential posting? Is it like, are you able to provide it for 12 weeks or is it like partial residential? Are you able to provide, or no residential posting is you are able to provide? So that is another challenge, like 12 weeks, or how is it happening at your place? At our place in Delhi, it is difficult to provide for 12 weeks of residential posting. Earlier for rural posting, we had residential. For urban posting, we didn't have. Now with 9 months of hospital posting, if you are posting one of the hospitals that we have an MOU with, that is in a rural area. So there we can post, but we don't have enough rooms given to us because whatever rooms have been given, there is complimentary from the state government. So we need to explore. So right now we are not able to give 12 weeks of residential posting to all the interns. That is one challenge we are facing. So partially we are able to give. So all the interns, we will try that all the interns will get some exposure of residential posting, but 100% students getting 100% of residential posting time is not possible for us. That is what we found. We would like to know your feedback. What are you facing?
Sir, this is Dr. Sujit, sir.
Yes, Dr. Sujit.
Yeah, I think it's not mentioned in the document that it should be residential, I think.
In the document, like 12 weeks it is mentioned, and in bracket it is written residential.
Okay. So it should be residential as per the document.
It is written 12 weeks, duration 12 weeks. And then in brackets, beside that 12 weeks, it is mentioned residential.
So that may not be possible for us, sir, because
So how much is it possible for you all, Dr. Sujit, at your place?
not at all, sir. They have to go in the morning, come back in the evening.
Not at all. So that's a big challenge.
Yes.
Okay. What about others? Is anybody able to provide at your place?
Sir, this is Dr. Anil. When we
Yes,
spoke
doctor.
to Taluk Hospital authorities, what we found out was that 3 weeks rotation for 9 weeks we can do that in these three subjects. Only on the duty days, they might have to stay over there when that particular person or particular specialist is doing the duty. So under him, if certain interns are there, so one or two
Dr.
interns can.
Anil, your voice is very feeble at this end.
Uh,
Can you be a bit nearer to your mic or try
yeah, yeah.
to speak in a louder volume because we're not able to get you?
Yes, sir. Can you hear me now, sir?
This is better.
Yes, sir.
Please.
When we spoke to the Taluk Hospital authorities, what they said was only on the duty days when that particular specialist is posted. So one or two interns can be, doing the night duties over there because it is very close by to our college. Rotation wise, they can do, but not every intern has to stay in that particular place for the whole of these 9 weeks postings, sir. Only on the duty days, whoever is there. So on rotation wise, they can stay there. So that can be considered as residency program, sir. That was my question.
Yes, so I think ultimately it will be the NMC what they consider it as residential, what they don't consider it as residential. But yes, we are what we are discussing is these are the challenges we are facing. That residential part is a big challenge that we are facing. Earlier also we faced, and currently also we are facing. So yes, we at your place, like for some days or some weeks, maybe people are able to post for residential posting, but 100% is not possible. That is an obvious challenge, and all said and done, like we don't have a magic or some superpowers to change these things. So we will have to bring it forth and highlight these issues that we are facing. Uh, Dr. Manoj has mentioned, I think, that introducing CBME pattern of internship with mandatory and new electives to last batch. It is like a pilot study. Yes, Dr. Manoj, it might be. It might be. We don't know. So, any other? So, I think this issue is a challenge for everyone. It seems like most of us. Uh, Next point that I want to discuss is there are points mentioned like I will talk about competencies, family composite healthcare, inventory of vital events, epidemic management activity, infectious disease surveillance, and modules on this safe rehabilitation, this nutrition surveillance and rehabilitation, safe motherhood, and all. So I will just put it in the message box so that everybody can see. And I would like to discuss how this will be done, or is it being done currently in your place? Was it earlier being done before these new guidelines came up? Like family composite healthcare and inventory of vital events. So how are you understanding these concepts? Like what is meant by family composite healthcare and inventory of vital events? So I think we all have not reached at that stage, maybe.
So what I understand by that family composite care is longitudinal care during the postings of the entire family, like family adoption studies, very much similar to that study. They are
Okay.
expecting us to do care of the family for longitudinal period. I think that is my opinion.
Okay. So that family composite healthcare, do you think that it might be like a longitudinal care being taken by the community medicine department or the interns?
It's by the interns, I think, sir. Probably it's an extension to the family health, family adoption scheme. Like
So you think it is an extension to the okay. Any other suggestions and comments on this aspect?
Sir, I think that these interns can be tagged along with these ASHA workers, ANMs and all. And when they are visiting these families, so they will be learning the overall, composite care what they are providing to the family, as well as they will be maintaining these vital events with them, sir. So how to maintain these vital events, like how to record it with different, systems available. So those things, if interns are made aware, I think that should be doing this competency, sir.
So, so one thing is like one point that is coming up. It can be interpreted as it is being interpreted as like extension of the family adoption program. Another is maybe Asha, how she is following up with the health of the families members in the community. So, okay, and inventory is the records that she maintains. Okay, the frontline workers associated with frontline workers. Any other family composite like inventory of vital events? We thought that and even I say that when I say we thought about it, we are not sure whether that is the correct way of interpreting it, because the details have not been mentioned in these guidelines. Everything is left to interpretation. So family composite healthcare, we thought an inventory of this, that interns will record vital events in the community from some family members. We can allot some families to the interns, but the point is that interns are being posted in community medicine department for 3 weeks. So they will not be able to do a follow-up kind of thing, a longitudinal thing in the internship program if we start from there. And yes, but the next batch of interns, so if today some interns study about some family, and then the next batch of interns, when they come, they carry it forward. They also, after maybe after maybe like 3 months or 6 months, when that intern batch comes, then we give them the family which was allotted today. So maybe every 3 month or 6 month interval, that family receives some interns, and the intern studies that family, and in future the intern knows that earlier this was the history, and this was captured by the earlier batches in that family. And now, so gradually that longitudinal aspect will develop in the those family folders. I think that has been mentioned by Dr. Smita ma'am also, preparing family folder with the help of medical workers and then following them up by successive batches of interns. So that can be, and that can serve as an inventory also, and that can help in understanding about family composite healthcare, because they will understand about the family. I don't know whether it can be thought of as an extension of family adoption program, because the reason is that in the family adoption program document, they have stopped at the phase 3 part 1. The family adoption program document clearly mentions about how many hours is to be allocated in first year, second year, third year part 1. So I think that family linking it to family adoption program, if possible in certain scenarios, seems to be a good idea. But whether the family adoption program and family composite healthcare is the NMC intends them to be linked, that we don't see any connection anywhere in the document. Neither in the family adoption program document we see anything extending beyond the third prof part 1, nor are we seeing in the internship document anything mentioned about the family adoption program. So one can, if one want to, because it is good to have some longitudinality, and you can build up. Nobody stops doing anybody from building up the longitudinal teaching learning. But I think by the way the documents have been framed, it doesn't link it by themselves. So it's not mandatory that we should link it, but if one can, they are most welcome to do so, I think. And family folders, and the way we can develop a longitudinal program in internship, that we'll have to search for. Dr. Manoj has mentioned it is like to motivate all the medical colleges to follow the best practices of the institutes, where community medicine department practices doing the family composite healthcare by maintaining the family health folders with the staff of RHTC, UHTC, who have made it electronic as well. Yes, Dr. Manoj, it seems like earlier also we had these family folder concept. I think almost all the urban and rural health centers had this family folder concept. But during the course of time, uh, some or most missed that particular thing. So maybe it's like a revitalization of that aspect. So certain points we have discussed. What do you understand by like epidemic management activity, infectious disease surveillance? How will we do that for all the interns? Like epidemic outbreak management and all, they will happen in the community at some point of time. It's not that every time it is going to happen. So, and infectious disease surveillance, for infectious disease surveillance, we think that any infectious disease which is endemic in that area, like maybe malaria in some area, maybe typhoid in some area, maybe some other dengue, even for that matter, diarrhea. Um, or COVID. So if there are certain tuberculosis also. So if we can have infectious disease surveillance kind of thing for certain infectious diseases, but epidemic management activity, I don't understand how can be done for all the interns. So any thoughts on this? Like I told, what is my understanding and where I am struggling.
So
Have you all reached this stage? Yes, Dr. Anil.
sir, for infectious disease surveillance, we can actually make them work in this IDSP program, sir. So if the college is doing it, or if the centers themselves are doing, where we post them, so they can handle this, IDSP, how it is being done and how it is being,
Yes,
noted.
yes. IDSP seems to be a good suggestion, linking them with IDSP. Dr. Anil, what is the IDSP related work that is being carried out in your community medicine related domain, or in within the ambit of community medicine? Is it like for you, is it possible for you all to give exposure to IDSP for interns posted with you in community medicine?
Yes, sir. Actually, what we were doing in one of my previous colleges, it was the work of Department of Community Medicine, where we had to collect all the notifiable diseases which were in the OPD and as well as in the inpatient. Bring a
Hmm.
list of it, and then we ourselves used to upload it to the IDSP, sir, like through the proper channel. So that way, the interns used to maintain, like, what are the cases which are coming.
Okay,
And
so Dr. Neil, you mean this infectious disease surveillance for the patients who are coming to the centers, from
yes,
there recording patients from there, like what diseases are being reported. Is it
yes,
so?
sir. Or
Yes.
one or two days we can keep them in our own medical college only, and they can monitor like how this work is being done, sir.
Okay. Yes, that is a good suggestion. And even I think those hospitals where they are posted in medicine, surgery, and gynae, if they are also reporting to IDSP in some way, because surveillance is going on in a hospital, CHC or district hospital, so we can tell them that this competency can be achieved there also, infectious disease surveillance IDSP, if it is there in that hospital. Yes. Thank you, Dr. Anil. Dr. Manoj has mentioned in the message box, difficult for all the interns, as you said. CM department in many states gets involved in the epidemic management, especially like in Kerala, on time to time basis. Interns can be involved, but now the time has come to make it very much involved with the district health authorities to make our department involved in surveillance and response for epidemic. Yes, I think Dr. Manoj, the intention and the idea seems good, but when to post and how to post, because 9 weeks they have to be posted in hospitals, and 3 weeks they are posted in centers. So for this we need a separate, like if they go to the hospital and it is mentioned they have to be posted in medicine, and I would have appreciated much more if the document would have mentioned like 1 week of posting in hospital along with the hospital administration managing, looking at all these aspects or managerial aspects. But when the document mentions medicine, surgery, and gynae, then we can't ask the hospitals to post them in hospital administration related activities and tasks. but giving attendance from medicine department or surgery or gynae department, that the medical college will find it difficult. The district hospital or the CSC will find it difficult to do, as per the guideline mentioned medicine, surgery, gynae. But yes, you are right. I think that should be the thing. If they can get exposure to some hospital administration managerial activities along with the district health authorities, that would have been a maybe. As we move ahead, this might be revisited and it might come up. Thanks, thanks a lot. So, any other point related to this? There was one more point, like this document mentions. What do you understand by the modules on? It mentions modules on field practice for community health, like nutrition surveillance, rehabilitation, safe motherhood, diarrheal diseases, etc. So, what are these modules? We thought like these modules are the modules that are there with the frontline workers, health workers like ASHA, ANM, um, this medical officer at the PHC. There are various modules. So we thought for the interns to get to give them exposure to the modules is related to these conditions like safe motherhood, nutrition surveillance, and rehabilitation, and this other point also, diarrhea. So which is there for the frontline workers. So that was our idea, but how to do it, that we'll have to figure out. So what is your understanding about this model? If you have gone through this document or right now, whatever comes to your mind, please share. I would like others also to please give your inputs related to internship in community medicine. Any query, any comment, anything that you have in mind, please speak out. It will be very helpful because we don't have anybody else here to help us in this. We all have to develop our own ways and understandings and share and enrich ourselves.
Sir, am I audible?
Yes, Dr. Sujit.
Yeah, I think this module thing in earlier internship documents also there is mention about the intern should be able to what you say do whatever that module is given for medical officers. Certain modules are given for medical officers for the implementation of national programs. Probably this is the same thing like you should be part of the implementation of that module that is necessary as a primary medical officer. That is my opinion.
Yes, so I think yes. So we are thinking on the same lines that the existing modules that are there, we will have to now keep it upfront for the interns to know about it and practice according to that. Any other comment on these modules if there are there? Transportation issues. Are you having transportation issues? Are the students interns going by themselves to these places, or is it like the college has to provide transportation? And we at our place now, with this posting at the hospitals becoming mandatory, now we are feeling the pinch of transportation issues. We'll see how it gets resolved, or the students might have to go at some places on their own. Till now, we were providing transportation issues to all the interns for all the postings. But now with this posting to more than one secondary hospital, so much of suddenly arranging so much of transportation is a challenge. Over time, it may be resolved, but Dr. Shri Vidya has shared her experience. Transportation issues are there, but not yet planned. We are striving for permissions. Yes. We don't have transportation facilities. Okay. So interns will are going by their own mechanisms, right? Okay. Transportation issue. I think there are transportation issues. So, what about the logbook? Like, any idea about the logbook, like how you have made the logbook? I forgot to share in the WhatsApp group. I will share the logbook that we have designed. I will tell you just now in short, like the logbook for internship in community medicine. The logbook, the NMC guideline regarding internship, it mentions that there must be logbook which the logbook should consist of the following competencies, and they have to be divided into these subheadings. Like one subheading is that able to perform independently. Another is like able to perform under supervision, and another is observed or assisted. So these are the 4 points that are mentioned. So these 4 levels are, I will repeat: observed, oblique assisted, observed, oblique assisted. Then another is they have mentioned under supervision. They must be able to perform under supervision, and one they have mentioned able to perform independently. So when we mentioned about these competencies in our logbook, we thought that observed and assisted, we put it in one column, like observed, oblique, assisted. If it is there, we will put a tick mark, a check mark there, and that will be there. For some competencies, like another, now the other 2 are under supervision, and one is perform independently. Now the issue is that interns allowed to perform anything completely independently. So if we mention something like the intern is able to perform independently, so what does that mean? As on one side, we say that internship must be under some supervision always, because the intern is not yet a licensed medical practitioner. And on the other side, one one part mentions here in this guideline, perform independently. And another list of tasks are there, which is to be done under supervision. So we thought we will keep all these tasks under supervision only. And so we were in a, like, it was a struggle. We wanted to simplify the internship logbook. We didn't want to complicate it too much. So we zeroed in on 2 aspects. One column is like observed or assisted, that is one. And second is under supervision, independently under supervision. So we took that route. That is our understanding. I don't know what others, how you have interpreted. You must have also modified your logbooks at your places. So how does your logbook look like? If you can share, I will share ours in our WhatsApp group maybe tomorrow. And you all also can share what how you have developed, so we can see if we can learn from each other's logbooks. Also, right now, if anybody wants to share how they have modified the logbook, please do that. Not done much work with logbook yet, or even the hospital, like, will the logbook be filled by the hospital authorities when they are posted to the hospital, or will the logbook be filled ultimately by the community medicine department only? Are you giving some components to the hospital authority, like CHC or district hospitals? We, at our place, we came to a consensus that it will not be possible to get the these things filled from the hospital authorities. They will not be able to do that. So so we will have to, we will do it at our from the department only. We will be doing this. From the hospitals, we get usually no dues, attendance, and these things only, not assessment of competency as such. So any input on that, if you have thought over this?
Sir, if we don't give the authority to the district authorities to sign, then they won't have a hold on these interns now, sir. What they say, will they be doing it?
Okay, so competencies. Are you saying competencies like saying that the competencies have been covered?
Yes, sir. Like we give them the set of things what the interns have to be done at this
Okay.
point of time. And if they are not able to certify that, and we ourselves are certifying that, then their role, it decreases in that, I feel, sir.
Okay. Okay. Yes, that is one point that yes, that is certainly that will be an issue. If we are giving them like attendance related authority, like attendance, and do you think when I say do you think, the question is open to all because we all are deliberating on this. That just giving the attendance related hold authority to them will not help in like they will not be able to control. Do you think we should give them this also, that they should? Yes, that is better way to do this, because they will be, if they are able to certify the competency, that would be much better. But is it possible at all places, or at, because we found that how much those secondary hospital like CHC, those doctors at the CHC and those docters at the district hospitals, whether they will be able to assess those competencies in that way, and what will be the basis of saying completed this task, not completed this task, and once they have mentioned, it will not be possible for us to change that in any way. So what dynamics goes on in those hospitals between the interns and the hospital administration, that part we thought that that is why that assessment part we are not very sure about it. But yes, you are right, that is a better way, I also think, that to get the assessment of the competencies done.
Sir,
Yes, Dr. Vishweshwara.
like the hospital staff, doctors may not eligible to get the competency, so certify the competency. We'll give some checklist like items. So based on checklist, department will give certificate
Acha.
of that competency.
Okay. Yes, that can be another way out. Yes, we can give a checklist, and they will give on the checklist, and then finally we will write on the log.
Department HOD or intense coordinator will
Yes.
certify that.
Yes. Yes, Dr. Smita has mentioned attendance related hold is necessary. We have to include, yes, attendance, definitely. We all, I think, agree that attendance related hold is necessary. In the hospital also, we should give them that if the students are not, interns are not attending the hospital posting, then they will have to mark them absent. And we will honor whatever the hospital's attendance, whatever they give. So certifying competency, but they are, will it be valid that we are certifying competency, but they are done under hospital? I think that we have discussed now that maybe we can give them a checklist and final authority we keep. Or if one wants to give it to the hospital to do the final certification, that is also fine. So I think one question was, is it mandatory to provide a transport to interns? It is not mandatory as such. When the mandatory, there's no mention of anywhere that it is mandatory. But hospitals and colleges try to provide the facilities if they're in internship, and also they try to provide facility. In some colleges, it is there for all the postings and all. In some colleges, it is not there. Maybe for some hospitals, it is there. For some, it is not there. But it is not like mandatory. I can't say mandatory. You're right.
Yeah, I have one more question, sir.
Yes, please.
Sir, like when you say it's competency-based assessments and competency-based checklist and all. So now the time we are giving is 3 weeks in each posting. Probably all may not be acquiring those competencies. So do we expect them to extend the posting if they are not acquiring those competencies?
Yes. If the competencies are not achieved, obviously, then because if you look at the logbook, we saw that the logbook mentions A, B, C, D, E, like 5 categories, and the last category they mentioned need to be repeated. So there will have to be a repeat posting if the competencies are not achieved. So either by way of attendance or by way of competency, the posting might be repeated. So if a particular department feels that the student is not up to the mark for certain competency, then that department, if mentions in the logbook that it has to be repeated, then it has to be repeated. So you're right on that front. I don't know how many of us will be able to do with what degree of validity and reliability this part of assessment of interns. But yes, that option is there in now in this internship program that if a competency is not achieved, then a department has that authority to ask the intern to repeat the posting. Maybe for 1 week, maybe for a few days, maybe for 3 weeks. That will depend upon the competencies and the attendance during that posting.
Thank you, sir.
So I think we have discussed all the issues. I think Dr. Malatesh is here, Dr. Prasad Pore is here. Any comments from Dr. Prasad sir and Dr. Malatesh regarding this change internship, how you are managing, how you know others are managing? Because it has come up all of a sudden. Earlier we were thinking that it is for the 2019 admission batch, but later on we found out no, it is for the internship starting right now. Yeah, Dr. Prasad sir, please.
Yes, good afternoon. Actually, I joined late, so missed a lot of things. The convocation of university is going on. But few things what we encountered a problem. One is about the getting the permission from the government for posting of the intern to CSC. So we are still struggling with that. And second, another issue that we encountered is about the how to rotate the interns equally in equal department, because the distribution of these interns becomes a really big problem. What I sometimes say, because the duration of departments are very differently, and as usual, it is the responsibility of community medicine to rotate the interns equally, and that is a big challenge. To some extent, we are did on ourselves, but still there are some lacunas in that we are getting. Hopefully, maybe next year we may improve in that one. Maybe for the odd batch, we can try for something new in that. But that's a two worrisome thing what I personally feel. And when the students
Yes,
are
that we discussed about it. The one is about getting permissions is getting difficult for some medical colleges has been mentioned in this. And so that I think we need more clarification and more. What comes to my mind is that the NMC should also send a letter to the Ministry of Health and Family Welfare and send it to states also, that you should welcome and facilitate the internship posting in your college, because if, right now this direction has come to the medical colleges. So it's like the demand is generated, but the supply side, that also has to be geared up. So maybe like this deliberation that we are having, whatever points come out, we may form a document or something and we can send it to NMC also. We can try to also put it in some journal also, maybe some opinion or some consensus or some perspective article kind of thing, so that this is highlighted, these issues that we all are facing related to implementation of CBME. We will have to highlight these issues and we will have to bring it to NMC also, and more clarifications, and also we'll give some suggestions how can this be done. When you talked about rotation, Dr. Prasad, what do you mean by rotation equally, like within the community medicine department, or are you saying beyond community medicine also, like pediatrics and radio diagnosis, other departments and community medicine?
yes, all because it's entire 52 weeks rotation I'm talking about.
12 weeks
That
rotation. Okay.
becomes a headache, especially for us.
Yes. 9 weeks, and earlier it was like 8 weeks, so 4 weeks. It was very easy to equally distribute. divide them into rural and urban. But now with the 12 weeks, 9 weeks, and 3 weeks, that is a bit of a challenge. And we have some places we have 2 CHCs, and some places we have 1 district hospital, 2 CHC, or 1 CHC. The combinations are different. So in that way, everybody has to make their own way of distributing, and that becomes a challenge. That at any given point of time, we have the same number of interns. That is always desired, but it might not be possible in this scenario that we are facing. Any other point, Dr. Prasad? You have to.
No, sir. No, sir. So we.
Thank you. We will share the recording or the transcript of the recording, some main points from this meeting. With all your permission, we recorded this meeting, and we will share the points from this with you all, what has emerged. Or maybe we'll share the recording itself. I don't think it will be a problem.
Yes, sir.
Dr. Shilpa has mentioned, sir, in future days, if such meetings are conducted on family adoption, how can you, sir, from which WhatsApp? Okay, Dr. Shilpa, we shared this in our, there was one CBME in community medicine workshop course that was conducted last to last year. So in that, there are around more than 100 faculty of community medicine. So it is not an initiative from any organization or something. I and Dr. Somdatta in our department, we were there in that course, and our faculty in that community competency-based CVME course for community medicine, there are around 10 faculty members in that. So we thought that we are facing these issues. Let us discuss it. So we shared in one WhatsApp group that was there, and we thought that we all have to discuss, brainstorm, and see what points are coming up. And when we know that others are also, we all are going through the same kind of thing, it gives us like strength also, and we don't get hopeless easily. It's not otherwise, if we are facing some challenges alone, it becomes difficult to cope up with it. So we thought that let us start having these deliberations. Whatever challenges we are facing, from time to time, we will conduct such online meetings where we don't have any presentations. There are no set guidelines. There are no instructions to be given to anybody. We are just discussing about our challenges as colleagues, as friends, as seniors and juniors. So let us continue, because family adoption program is another thing. So as has come up in today's meeting, we didn't plan for it, but now I think that we can deliberate on that also. Maybe after a few weeks, we can have that. So there is no specific group as such which is leading this, but maybe from where you have got this invite, this Google Meet link, Dr. Shilpa, can you tell us? Then maybe you can get it from the same group or person in the next meeting also. Are you there, Dr. Shilpa? It will be better if you can unmute and speak out, so that we'll be able to better understand each other. Yeah, Dr. Shilpa. So
Yeah. Good afternoon, sir.
yes.
It's from the same group actually. My common friend, she has joined that CBME group. I think it was 2 years back, most probably. But I'm not in that group, sir. So maybe
Okay.
she may share when the session is planned for the next meeting, sir.
Yes, fine.
Good afternoon.
Or if you want, you can, Dr. Shilpa, you can send me your number. We can make think about expanding the same group, WhatsApp group, the CBME Community Medicine Course Group. It has many number of faculty members, so we can expand that group. We can add more those who are interested to join that, and we can have some deliberations on common issues related to community medicine.
Okay, sir. Dr. Shalini is there, sir, in meeting. She is a member of that group, sir, CBME group. She
Yes,
has
Sir, I had attended that workshop last time. I sent her this.
Yes, Dr. Sharanya.
Yeah, I was in the CBME workshop last time, so I sent it to madam.
That's great of you. That's very we are also very thankful to you that you shared it with your colleagues. So I think in future also we will be posting in that group only. That is, we don't want to spam in many groups and send so many. It's not something like it just some deliberation with our colleagues. So it's not some kind of presentation, advertisement, or something like that. So that is why we don't want to just we don't want like more numbers or like more of this. But yes, those who are interested, definitely we should be able to reach out to them. So we will try to reach out to more people, and you can send us your this mobile number and name, and if you want to join such discussion, we will think about it in our group how to take it forward in a non-partisan way. That is important.
Okay, thank you, sir.
Thank you. Dr. Somdatta?
Yeah, Dr. Amit, thank you so much for summarizing and thanks to others actually for joining and giving inputs,
Do you think we have covered all the points that we were discussing in the department earlier? Or do you think there are certain other issues also that we need to?
No, I think all the issues, whatever we are facing, that has been covered. So I think that's fine.
Okay. So I think we come to the end of this meeting today, and we will share the video link with you all maybe in 1 or 2 days, and also some points that have come out with it. We'll try to see if we can send to NMC, or we should bring it out as a where maybe a letter to editor or something, just to highlight it at some place that these are the issues that we are facing. It's not a typical research or survey methodology that we are adopting, but yes, whatever we are discussing, I think many of us are facing these issues. So these informal discussions should also be considered. So thank you, everyone. If there are any comments, any points, that last comment anybody wants to put up, you can put up.
Thank you, sir.
Thanks all for joining and your sharing, giving your inputs. Thank you very much. So I end the meeting here. I will stop the recording also.